Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are focused, structured and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of rectus sheath into clear, high-yielding, exam-focused concepts. So let's get started. So firstly, what is rectus sheath? So what is rectus sheath? It is an aponeurotic sheath. So it is basically an aponeurotic sheath enclosing mainly the rectus abdominis muscle in the anterior abdominal wall. So sometimes along with the rectus abdominis muscle, it also encloses the pyramidalis muscle. So we can see the rectus sheath here. This is the rectus sheath enclosing the rectus abdominis muscle. So this is the rectus abdominis muscle, and there will be a small muscle here which we call it as the pyramidalis. So sometimes it encloses this muscle when it is present. So thus this rectus sheath is an aponeurotic sheath. So why do we have the rectus sheath? What is its function? So the rectus sheath, one thing it prevents the bowing of this rectus abdominis muscle. Now the rectus abdominis muscle is a straight flat muscle, long muscle, right? So whenever there is raised abdominal pressure, the muscle should not bow because there is no deep fascia there in the anterior abdominal wall, and this muscle should not bow. So to prevent the bowing of the muscle, we have this rectus sheath. And secondly, it also provides the strength, okay, it maintains the strength of the abdominal wall. So, mainly the functions of the rectus sheath is 1, it prevents the bowing, of rectus abdominis muscle, as well as it will, second thing is, maintains the strength. Maintains the strength of the anterior abdominal wall. Next, how is this rectus sheath? So this rectus sheath is basically formed by the aponeurosis of the three flat muscles. Okay, that is, we have the external oblique muscle, the internal oblique muscle, as well as the transverse abdominis muscle. So these are the three flat muscles of the anterior abdominal wall. And the rectus sheath is formed by the aponeurosis of these three muscles. So this rectus sheath here has certain features. So when we see the rectus sheath, it will have two walls, the anterior wall and the posterior wall. Okay, so it will have an anterior wall and a posterior wall. So if we see the anterior wall, it is complete. Okay, so the entire length of the muscle, we will see the rectus sheath. So it is a complete wall. Okay, it's a complete wall. And whereas when we see the posterior wall is deficient. Okay, is deficient at two places. One is above, it is deficient. Okay, so above, this rectus sheath will be attached to the 7th, 8th and 9th costal cartilages. So the muscle, rectus abdominis muscle above that level, okay, so above the costal margin, it will be in direct contact with the 5th, 6th and 7th, okay, costal cartilages. So here the posterior wall will be deficient, right? So above the costal margin, the muscle will be in direct contact with the 5th, 6th and 7th costal cartilages where the posterior wall is deficient. So here in this region it is deficient. Then it is also deficient below. So where is it is deficient? Below the arcuate line. So above the costal margin it is deficient and below arcuate line. So below the posterior wall presents a free curved margin and this free curved margin with the concavity facing downwards. So this margin we call it as the arcuate line. Okay, and this arcuate line has one more name. It is called as the line of Douglas. Line of Douglas. So that is nothing but the arcuate line. So below this level, again the posterior wall is deficient and the rectus abdominis muscle will be in direct contact with the fascia transversalis. So that is the next feature there which we see. And next thing is this anterior wall, if you see, it is adherent to the muscle through these tendinous intersections. Okay, we have these tendinous intersections between the fibers of the rectus abdominis muscle transversely, which are running transversely, and this anterior wall of rectus sheath will be attached, okay, adherent to the anterior surface of the muscle through these tendinous intersections. So that is about this anterior wall and the posterior wall. Posterior wall, in that case where this is adherent, that will be free. So you can see here this is adherent here, whereas in this case here it is free. The posterior wall is free. It is not adherent to the posterior surface of the muscle. So next we will see the formation. So the formation of the rectus sheath we will study at three levels, that is the above the costal margin, between the costal margin and the arcuate line, and below the arcuate line. So above the costal margin now. Okay, so the above the costal. So first thing is, how is it above the costal margin? Above the level of costal margin. So above the costal margin, what happens? The anterior wall is formed by the aponeurosis of external oblique muscle. Okay, so we see the anterior wall here formed by only external oblique aponeurosis. Whereas the posterior wall, are we seeing it? We do not see the posterior wall. So posterior wall will be deficient. So posterior wall is deficient here, and the muscle, when we see here, it is directly in contact with the 5th, 6th and 7th costal cartilages. Okay, so because the posterior wall is deficient there. So next is between the costal margin and the arcuate line. Between costal margin and arcuate line. Okay. So here now, so this arcuate line, basically it lies at the level between the umbilicus and the pubic symphysis. So at that level we see the arcuate line. Okay, so now between the costal margin and the arcuate line, how is the formation of rectus sheath? That is what we are going to see. So here if we see now the anterior wall. Okay, so here the anterior wall will be formed by the aponeurosis of external oblique, and so between the costal margin and the arcuate line, the anterior wall will be formed by the fusion of the aponeurosis of external oblique as well as the anterior lamina of internal oblique. So what is this? Here the internal oblique aponeurosis will split to form an anterior lamina and a posterior lamina. So here anterior wall will be formed by the fusion of these two, okay, that is aponeurosis of external oblique and the anterior lamina of internal oblique. Whereas the posterior wall, okay, so here the posterior wall is formed by the fusion of the transverse aponeurosis of transverse abdominis muscle as well as the posterior lamina of the internal oblique muscle. So that is the formation between the costal margin and arcuate line. And third is below the arcuate line. Okay, third level is below the arcuate line. So below the arcuate line, when we see, the anterior wall is formed by the aponeurosis of all the three flat muscles, okay, internal oblique, external oblique as well as the transverse abdominis muscle. All of them will contribute to the formation of anterior wall, whereas the posterior wall here is deficient. posterior wall is deficient, and the muscle will be in direct contact with the fascia transversalis. So that is below the arcuate line. So the recent studies are there are recent theories now about the formation of rectus abdominis, where it states that is formed by the anterior lamina of all the three muscles, and the posterior wall is formed by the posterior lamina of all the three. Okay, so it says that each of the aponeurosis is bilaminar and they will contribute to the formation of both anterior and posterior wall. So that is the recent theory. Right. So now, we saw the formation. So when we see the same thing in a transverse section, this is how we will see. We see the rectus abdominis muscle of both the sides. Okay, so this is the rectus abdominis muscle. So above the arcuate line, now here we center we have this linea alba. So this linea alba is formed by the decussation of all the three aponeuroses from both the sides. So here when we see the anterior wall, we can see the its formation by the aponeurosis of external oblique, anterior lamina of internal oblique. Okay, that is anterior wall will be formed, whereas the posterior wall will be formed by the posterior lamina of internal oblique and the aponeurosis of transverse abdominis muscle. Okay, so that is above the arcuate line. And when we come below the arcuate line, here we can see the muscle is in direct contact, that is the posteriorly it will be in direct contact with the fascia transversalis because the wall is deficient. Okay, so it will be direct contact here, and we can see the anterior wall formed by the aponeurosis of all the three muscles. Next, coming to the contents, what does this rectus sheath contain? So the rectus sheath contains two important arteries. Okay, so other than the two muscles which we know, so we have the two muscles. So which way the two muscles? The rectus abdominis and pyramidalis. Okay, so the rectus abdominis muscle mainly, and when the pyramidalis is present, it will also be present. So two muscles are enclosed. Then we see two arteries. Okay, so one is the superior epigastric artery. Superior epigastric artery. Now, superior epigastric artery is a branch from the internal thoracic artery, and we also see the inferior epigastric artery. So, inferior epigastric artery is a branch of the external iliac artery. So, both of these arteries they enter the rectus sheath where they will be anastomosing with each other. And we see two veins corresponding to these two arteries. Okay, two veins, that is the superior epigastric vein as well as the inferior. So, we can see here. So, this is the superior epigastric, this is the inferior epigastric artery, and corresponding along or running along with these arteries will be the two veins. Then we see 6 nerves. Okay, 6 nerves are seen. So, which are those 6 nerves? We will see the terminal parts of lower 6. Okay, the terminal part. So, if you see here, the terminal part of 1, 2, 3, 4, 5, 6. Okay, lower 6 thoracic nerves, which includes the subcostal nerve also. Okay, so this includes subcostal nerve. Okay, so and these are also accompanied by the terminal parts of the posterior intercostal vessels. So these 6 nerves are there. So these 6 nerves they enter, that is from the intercostal spaces into the abdominal wall. They will enter between the internal oblique muscle and the transverse abdominis muscle here. Okay, we can see this muscle is the transverse abdominis here. The internal oblique is reflected. So we can see the transversely running fibers of the transverse abdominis muscle. So between this muscle and the internal oblique, it will enter the anterior abdominal wall. Okay, so this we call it as the neurovascular plane here. and then it will enter the rectus sheath. So how does it enter the rectus sheath? By piercing the posterior lamina of the internal oblique. Okay, posterior lamina of the internal oblique muscle, aponeurosis. So it will pierce that, and within the rectus sheath they will further proceed. They will pierce through the rectus muscle, rectus abdominis muscle, and they come to the almost up to the midline. So where they will again pierce the anterior wall of it, and they become cutaneous. Okay, they become cutaneous, and then we call them as these nerves. When they become cutaneous, we call them as the anterior cutaneous nerves. Okay, so all of them, right. So that is their course through this rectus sheath. So next, coming to the clinical part of it. So the condition which we see commonly here will be the divarication of recti muscles. Okay, so divarication of recti. So that is nothing but the separation of the recti. So this occurs in multiparous, elderly multiparous women, where the anterior abdominal muscles are weak. So what happens is, whenever there is increased pressure, the muscles separate. Okay, so here the aponeurosis. Okay, so in this condition, the aponeurosis which forms the rectus sheath here, it becomes excessively stretched. Okay, because of the excessively stretching of the aponeurosis. Okay, so this excessively stretching of aponeurosis which forms the rectus sheath, okay, leads to this condition, right. So this can then lead to something called as the herniation. Okay, so when what happens in this condition, the aponeurosis becomes excessively stretched, and so when the patient coughs or strains, the recti will separate widely. And hernial sac containing loops of intestine can protrude between the medial margin of this recti. Okay, so the medial margin, that is near the linea alba, it can protrude. Okay, so that is what we see. This is known as the epigastric hernias. So here we can see, so this is the normal tone of the muscles in a normal condition, which we see this way. So whenever there is weakening, okay, so weakening because of the excessive stretching of the aponeurosis in case of multiparous women, elderly women, where because the anterior abdominal wall becomes weak because of the excessive stretching of this aponeurosis, the muscles will separate. So when the muscles separate, so what can happen is, whenever the patient coughs or strains, herniation can occur, that is a loop of intestine can protrude through the midline here, right. So we can see here the hernia protruding. Yeah. One more condition which we see in this region is the hematoma of rectus sheath. Okay, hematoma of rectus sheath. Now what is this condition? So sometimes the superior epigastric and the inferior epigastric arteries which run through these rectus sheath and anastomose, they can be unduly stretched, and this again occurs in multiparous women. Okay, and or in the later parts of pregnancy also it can happen. So because of that undue stretching of that, the arteries can rupture and they cause the hematoma. That is the collection of the blood in the anterior abdominal wall beneath the rectus sheath, and hematoma is formed. So usually it will present as a midline abdominal pain. So in the midline there is pain, midline abdominal pain, and a tender mass. Okay, so we can see a tender mass is felt in the to one of the rectus. If it is in one of the rectus sheath, we can see the tender mass is confined to one of the rectus sheath. So that is hematoma of rectus sheath. Then we have to understand about the epigastric hernia now. Now here the linea alba, okay, the linea alba, which is nothing but a fibrous raphe formed by the interlacing of the aponeurosis of all the three flat muscles on both the sides. Okay, so it is in the center, extending from the xiphoid process up to the pubic symphysis. We see the linea alba, and this linea alba is formed by the interlacing of the aponeurosis of the flat muscles from both the sides. So now this linea alba, it is wider, okay. It will be wider above the umbilicus. So above the level of umbilicus, the linea alba is wider, whereas below it is narrower. It is narrower. So this linea alba, it becomes weak in elderly multiparous women and also in chronically ill children. Okay, chronically ill children and elderly multiparous women, it can become weak, and when there is increased abdominal pressure, okay, increased abdominal pressure, what happens is the extraperitoneal fat, okay, so the extraperitoneal fat first can protrude through this linea alba, that is in the upper part above the umbilicus, okay, so that is why we call it as the epigastric hernia. Right. So I told you the linea alba is wider, okay, wider in the upper part above the umbilicus. It's about 1 centimeter wide. So here the extraperitoneal fat can protrude, and sometimes along with that it can drag part of the peritoneum also, which may contain the portion of the greater omentum. Okay, so here we can see first the extraperitoneal fat. Okay, this is the extraperitoneal fat will protrude. And later on maybe a part of the peritoneum along with the greater omentum can also protrude, and that we call it as the epigastric hernia. The next important thing here is in this region, that is in the anterior abdominal wall in the midline, we have to understand about the abdominal incisions. So the abdominal incisions, okay, so abdominal incisions are very common, because we need, when we have to do abdominal surgery, laparotomy to explore the abdominal organs or contents, okay, other structures, we have to put an incision on the anterior abdominal wall. And where we put this incision, okay, is very important for two reasons. One is during the surgery and later on post-surgery recovery or the healing. So here some of the commonly given incisions are, one is the midline incision. So this is the midline incision. So this midline incision is usually given along in the midline as it suggests, okay, on the linea alba. Now this is a very easy to perform. For a surgeon it is very easy because above the umbilicus the linea alba is wider. So because it is wider, we have a larger surface area there and we can put a midline incision, okay. And then what are the advantages of this? Why it is preferred, okay. So why it is preferred? One thing, the linea alba is a fibrous raphe. So because of which the blood vessels are less there. So it is almost bloodless, okay. So it will provide a avascular field. Second thing is, since it is fibrous raphe, there are no muscle fibers. No muscle fibers, okay. So no muscle fibers will be cut when we cut along the midline. Then there are no nerves, okay. So we learned that the nerves just before the midline, they will again pierce the anterior wall of rectus sheath and they become cutaneous. So there are no nerves also there, so no nerves are likely to be injured. And since it is midline, it will give access to both the sides, the right and left sides of the abdominal cavity. Okay, so it gives access, wider access. So these are the advantages of making a midline incision. Now the disadvantage is what? Disadvantage of the supra umbilical midline incision is there is no blood supply. So obviously the healing will be poor. Okay. So the healing is poor and it can lead to incisional hernia. So chances of incisional hernia is high. So in this case, the infraumbilical incision is much safer. If you want to put a midline incision, the infraumbilical is safer because here the linea alba is thinner and the muscles we can approximate. Muscles are more closer. Right. So that will that can prevent a incisional hernia. Next, we do paramedian incision. So paramedian incision is just parallel to these midline incisions. So here we have like this one. This is the paramedian incision here. So paramedian incisions, so in this the anterior wall of the rectus sheath is exposed. Okay, so in paramedian incisions the anterior wall of rectus sheath is exposed, then the rectus muscle is retracted. Okay, it is retracted laterally. So once it is retracted laterally, then what we do is we will put an incision. So when we put the, so here one more thing what you have to remember is when we have retracted it laterally, now its blood supply or its nerve supply is not affected. Okay, so the nerve supply and the blood supply remains intact of the muscle. Then the posterior wall of the rectus sheath, okay, the posterior wall of the rectus sheath along with the fascia transversalis is then it is incised. Okay, fascia is incised and then we reach the peritoneum is incised. So posterior wall, then beneath that we have the fascia transversalis, extraperitoneal tissue, and then we reach the peritoneum. So that is in the paramedian incision. So when we do the suturing, the wound closure, we close it by layers. Okay, so one by one layer. So in paramedian incision, the post-operative weakness and occurrence of incisional hernia is very minimal. So that is more preferred. Other than that, we also give now for to expose the gallbladder during gallbladder surgery. We do this Kocher's incision. So this is called as the Kocher's subcostal incision. And we have the McBurney's gridiron. This is in appendicectomy. We do this. McBurney's incision, this one, which is also called as gridiron incision. Then we give the transverse incision, the lower part. This is usually done for C-section. We give a transverse incision. So these are the different incisions which we give on the anterior abdominal wall. So here we can see now in this picture. So when we give a paramedian incision here, okay, so we expose the anterior wall and we will retract. So this is the rectus abdominis muscle. The rectus abdominis muscle is retracted. So now its nerve supply or the blood supply is not affected, and then we go down. So this will be the posterior wall, and beneath that we will go to the fascia transversalis, and then the extraperitoneal tissue and peritoneum. So that is how by layer we approach the abdomen cavity. So coming to the image based MCQs, which structure contributes to the posterior wall of rectus sheath above the arcuate line? Now above the arcuate line, the posterior wall is formed by the posterior lamina of internal oblique and the aponeurosis of transverse abdominis. So we will look at the choices. So with the choices, the most accurate choice would be the C1, internal oblique posterior lamina. Then below the arcuate line, the rectus abdominis lies directly on. So below the arcuate line, the rectus abdominis will be lying directly on the fascia transversalis, that is B. Okay. So peritoneum is below that, external oblique aponeurosis comes above, and linea alba is the center. Okay, so that is how we rule out the rest of the choices. The labelled vessels are, so here the labelled vessels coming from below will be the inferior epigastric vessels which we see within the rectus sheath. The anterior wall of rectus sheath above the arcuate line, okay, anterior wall is formed by the external oblique and the anterior lamina of internal oblique muscle, right. So, which is the right choice? The C is the right choice. An incision through the linea alba is preferred because, is it because highly vascular? No, it is bloodless. It contains major nerve nodes. We should not injure any blood vessels or nerves. Try to avoid the injury as far as possible, right. So, that is not the choices. It is relatively avascular, yes. It is not thick more than linea alba. There basically it is the formed by the interlacing of the aponeurosis from both sides, the fibrous raphe. It is just wider above the umbilicus. So that's a wrap on today's session of rectus sheath. So stay consistent with this series because they bring you one step closer to your NEET PG dreams. So stay consistent, stay focused and trust in your preparation. I'll see you in the next session.